What's up, man? Well,
Hey.
welcome to the lounge.
How are you?
Good to see you in person. I think this is our first ever lounge sitting next to each other.
Yeah.
I didn't realize you were so tall.
We see each other in person at work. It's not like you haven't seen me.
I know, but you're much taller.
How are you feeling?
I feel pretty good. How about you?
I'm shivering, and I don't know if it's because I'm cold or just so excited to be here.
It's probably a little of both. It's nice and crisp in here. We store meat in the back in the studio, so that's a little side hustle we have going on. Listen, we're so happy that you all can join us here today on the Critical Care Lounge. We are obviously in person, and this is what we plan to be doing in the future. I think there will be some virtual shows as we go, but our goal is to be live as much as possible.
Yep.
So thank you for everyone who's joining us. What we're going to be doing is we're going to be doing a very focused case. We have some points that we want to hit, but just a very fluid conversation. And as always, we encourage you in the audience to put your comments in if you have anything that you want to ask. And towards the end of the show, we're going to get to it. So you ready to go, buddy?
I'm ready.
All right. So what do we got today?
So we called it angioedema, but maybe we'll just make it a little bit just upper airway pathology and focus on angioedema, but allow it to drift wherever it goes.
Okay.
I have some cool cases that I think I've taken care of. We've all been affected by it. That scary airway that you're not expecting, it stays with you.
Yeah.
So let's talk about, here's a random case made up, but I think anyone who practices in the ER or in the ICU has heard this. And so I'll present a 41-year-old female, has a history of hypertension. Of course, she's on lisinopril, and she comes in because her throat is swelling for, 12 hours.
Admit to medicine.
Yeah.
Clearly admit to medicine. I think
Continuous pulse ox.
Yeah, right. I think as anyone who has worked in an emergency room or ICU type setting, you hear ACE inhibitor, you hear facial swelling, the first thing you think of is angioedema. And rightly so, right, that's the first thing that should be on our mind. But let me ask you this. How is she moving her air? How is she breathing? Does she sound stridulous? Give me a little bit more on the story.
Yeah. So you go in the room. She's a little hypertensive. She's breathing, we'll say 25 times a minute.
Okay.
Not hypoxic,
Mm-hmm.
but you can hear stridor. And I love to break down stridor, and I always find this so fascinating, is when you think about it, it's always expiratory, almost always expiratory. And the key hallmark to stridor is that it's also inspiratory. So you hear it throughout the respiratory cycle.
Right.
And you can hear some stridor. You asked her to cough because key point, a lot of times you cough and it's secretions and it goes away.
Right.
And you listen to the throat and you hear stridor and you're immediately worried that maybe there's something going on in there.
Yeah. So, I mean, at that point, I'm thinking IV O2 monitor. That's the mantra that we always say. But I think more importantly, I try to talk to the patient and I get a sense of how they're phonating.
Yeah.
I think you learn a lot by just listening to someone talk. There are people who I've been pulled into the room. They say, you got to see this person. They're short of breath. And they're giving me a soliloquy about where they were born and how many kids they have. I'm like, their airway is good. And they can talk. And then there's some people who muffled voice, secretions pooling, they can barely get a word out. And those are the people that make me scared.
Yeah, you're making me chuckle because I'm thinking about those patients who they have what sounds like a muffled voice or they sound a little different.
Yeah.
And have you ever been in a scenario where you go, ma'am, is this always how you sound? And they go, yeah, why? And you're like, oh no, they're talking about
your voice
like
is
they
good.
all raspy and they sound like 100-pack of smoker. They're like, this is always what I sound like. You're like, yeah,
Yeah, right.
yeah. I think that's great, and I think it gives you a ton of time. And I'm sure we're going to get into this, but I've seen so many times where we get ourselves worked up, where we think it's a larger emergency than it is. And I'm not trying to downplay it, but sometimes you walk in and yeah, their tongue is swollen, that they have angioedema, but it's been like that for several hours. And the pace is a little bit slower than what we built it up. And then we force ourselves to try to do things, get into trouble.
So then if we can put angioedema into a box, or we should probably talk about anaphylaxis too. These patients come in, they have airway swelling. What boxes are you putting people in, anaphylaxis or angioedema? Does it matter in your treatment and your approach to it? So what's your thoughts on that?
So I think understanding exposure is important. And so when you talk about anaphylaxis, for the most part, there's a story. I was stung by a bee, or I'm allergic to shellfish and I ate at a picnic and something happened. There's usually a story. And I think they come in hot. They're flushed, they're hypotensive, they're tachycardic, They may have upper airway things. They have lung pathologies going on. There's the systemic effect that's happening, and that's different than the angioedema. But there's some overlap, right?
Right.
Because the mechanism that's driving anaphylaxis, histamine, can also drive angioedema, which is different than our ACE inhibitor-induced angioedema,
which is bradykinin. So then maybe we'll put the anaphylaxis to the side, even though sometimes it could be really hard to tell. Maybe let's focus on the angioedema. Let's focus on those two branch points you talked about, the bradykinin induced and the histamine induced. So someone comes in with a histamine induced, and they can look very similar to the anaphylaxis, right? They have diffuse erythema. They have also the upper airway swelling, all the things. And the person with bradykinin, do they look any different than the person, besides historically, any difference in their presentation, their look?
I generally think the histamine as systemic, flushed, urticaria, pruritus, lung can be involved, bowel can hyperactive bowel sign, everything. They just look a lot sicker.
Yeah.
And bradykinin is usually just tongue swelling and localized. They generally don't have any skin manifestations.
Like pruritic.
Yeah.
They may have like their swelling of the lips or the mouth.
Of course. And they're actually honestly hypertensive because they're like in respiratory distress.
Yeah, and they didn't take their, or they did take their, they did take their ACE inhibitors.
Yeah, that's right. They have. So I think they look different. I don't know. Do you have anything to add?
No, to me, maybe I'm oversimplifying it. Please correct me. You often do. Is if you have somebody who comes in and they look like anaphylaxis, I also don't think too much whether or not it's anaphylaxis or if histamine related angioedema. I'm probably going to treat them the same.
Yeah.
And the people with the ACE inhibitor or the bradykinin induced, I keep saying ACE inhibitor, but there are other drugs that can cause the bradykinin mediated. Those people usually have just focal swelling. They have just focal swelling of the lips. Sometimes you can get some asymmetry, although it doesn't have to be. But it's like focal lips, tongue, facial structures, posterior structures of the mouth. Patients with familial can also have patches throughout their body that are not like pruritic, but they can have other parts of their body that are swollen as well. So that's the way I approach those people who come in.
I think one point I would definitely, I completely agree, but one point I would for sure make is that if I'm worried about anaphylaxis, I give epinephrine. ABCs, fluid resuscitate, and the question is IV or IM, and the answer is whichever is faster.
Yeah.
And so the time frame, and maybe I don't work in the ER, so I don't know this, but I think about bee sting, and it's usually less than 30 minutes, less than an hour.
Right.
And they get super sick fast, right? Maybe ingestion's a little bit slower, but and so if I'm worried, I get epi.
Yeah. Epi is one of those things that I find that people hesitate a lot, especially if someone's like a little older or they have coronaries. They're like, I don't know. I don't want to give epi. And I know we're not talking about asthma here, but in every study that you look at, when patients are in severe respiratory distress, they're tachycardic, they're hypertensive, those vital signs are there because the person feels like they're going to die. And so I don't hesitate to give that person epinephrine because those patients' vital signs will get better once you make them feel like they're going to live again. So I don't hesitate with epinephrine. Give the epinephrine early. IM is the faster one for me, usually in the emergency room, even the ICU, to be honest with you. But at the same time, I'm asking that nurse also to pull an epi drip because the rate limiting step after the 2 doses is we got to get that person on an epi drip and start titrating to effect.
That's great. Okay. So you were trying to push the conversation forward and I made you go backwards. So let's get to the original thing. So you're asking about drugs and how do we treat, I think that's really the question. Is how do we treat bradykinin versus histamine mediated angioedema? So I find that the vast majority of patients with any upper airway swelling have already received steroids, Benadryl, and Pepsid, right? Before I show up. So the question is that right for all patients, especially if they give a clear example of being on lisinopril?
Yeah, that's a tough one. I would say you could be really academic about it. There goes the plant.
I'm destroying the lounge.
The budget on the set is.
Sorry, guys. This is the last time I'm going to be invited here.
So when it comes to ACE inhibitor-induced angioedema, I think there's some people that want to give the histamines, they want to give the steroids, they want to give the epi, but there's just no data behind it. So if you have somebody that has a rock-solid story for a bradykinin-induced, especially if they're on an ACE inhibitor, which is like a story that we see classically emerge, I don't feel a need to do that. Can you give it? And is there no harm? Yeah, sure. But again, I try to give the medications that I think if there's any confusion, if the person gives an unclear story or they're not sure if they had itchy skin or whatever,
Yeah.
I won't hesitate to give it. But if they just have a bradykinin induced, I don't feel the need to give it. How about you?
Yeah, I'll be honest. If you're going to write things down that I say, I hope this is one of them, is that I'm a fan of making decisions. So what I'm not a fan of is going back and forth where someone starts the steroids and then someone stops the steroids and then someone starts the steroids. And so I think if we're on the pathway, decided that we're going to give steroids, we're going to treat this as histamine mediated too, then I continue it. But I agree. There's times I also will say that I'm quick to stop once I really decide that that they're improving, it's not needed, then I'm quick to stop.
Yeah.
I don't know if that answers your question.
Yeah, that's absolutely fine. And again, you could be all academic all day long and say there's no need to give it. But listen, in that moment, and I find the people that criticize are the people who have not been in that moment where that person's in front of you. When that person's in front of you and the poop is hitting the fan, absolutely no problem with giving it if you're unclear. And then, of course, we already talked about with the histamine induced, you're giving all that stuff, right? We're giving the antihistamines, the 2 classes of drugs, we're giving the steroids, and then we're giving the epinephrine in hopes to reverse. Okay. What else do we have in our arsenal medication-wise to give for these patients? Let's talk about for the histamine induced, is there anything else or just keep giving them all the epinephrine?
So for histamine induced, so I think beta agonists, we didn't talk about that. I think that there's role for beta agonists, especially if you hear wheezing and pulmonary effects of it. I think if not all these patients need to be intubated, I think we'll have time to talk a little bit about that. But my preference would probably be high flow with heliox. I try to get that laminar flow, try to oxygenate and ventilate, get rid of dead space, clear the dead space as much as I can with high flow, as high of liters per minute as they can tolerate.
Right.
I think those are most of it. Do you have anything else?
No, I think that it's just supportive care. And the real goal is which we'll get to in a little bit, is where do you draw your line? Like the medications aren't working, the airway is becoming threatened, because ultimately that's the thing that's going to be most worrisome. When do you take it? But we'll get there. And by the way, just as a reminder, everyone, please drop your comments in, be part of the discussion. That's what the lounge is all about. We're monitoring the comments right here on the screen. So anything that you got, let us know, and then we'll address it as we go. So then let's talk about bradykinin induced. What is your approach to that? In terms, we already talked about plus minus those medications.
Right.
And then is there any medication that you can give for these people?
Part of me is tempted just to say no and move on and then wait for the comments to come up, because that's probably what people want to talk about is FFP and TXA.
It's sexy.
And so it's sexy. And so let's do that. So I give FFP. I generally give 2 of FFP for these patients.
Okay.
I think that the real benefit to FFP is in hereditary angioedema, it's E1 esterase inhibitor deficiency overcoming it. But I give it because I think there's a little downside. It's really interesting though, because FFP, like a very small percentage get angioedema from FFP.
Yeah, right.
So I always ask that. But so I do that. But really, there's the one study I always remember. There's better stuff out that I haven't read, but the one was like 100 patients of clearly ACE inhibitor induced angioedema. They gave FFP.
Yeah.
And all the outcomes were the same, except for ICU length of stay and number of vent days was lower in the FFP group.
Right.
But 100 patients observational. We don't need to get too geeky about it, but I don't know if that's like convincing that we should change the way we practice.
I have a friend who considers himself to be the angioedema expert of North America. And he is. He does a lot of research. I'm not going to shout out to embarrass him, but he's the person like I text and I call when I have questions on this stuff. And when FFP became a thing, I had asked him, what are your thoughts on it? He goes, it's hard to know whether or not the FFP is, because it takes time to get the FFP, right? You got time to screen them and they get, so it takes time. So by the time they get the FFP and they get administered, they start to get better. Are they better because they would have gotten better? Or are they better because of the FFP? That's a hard question to answer. That's one that, and again, FFP is not a risky transfusion, but it is a transfusion. We know the risks associated with transfusions. I put it a little lower on my list. I will consider it, but I might go for something like a TXA first. Yeah.
Although I want to stop for a second, because just to remind everyone, this is a show where we invite experts on the show to discuss a topic. And Dr. Malamat just admitted that he knows the world expert on angioedema and chose not to invite him on the show.
No, it's our show. It's our show. And there's not enough room on the couch for 3 people, right? We don't have a big budget, as you can see.
All right. TXA, I've never given it for for angioedema. Maybe I should. I think that there's the thought process behind giving TXA is that it reduces bradykinin release downstream. That's the thought process. And similar level of probably data evidence in terms of like observational small studies, some case reports. How,
Yeah.
I guess you give it IV, right?
You give it IV, a gram. And to me, it's look, to jump the shark, it's like what I'll give TXA first. If that's not working, then we'll go to FFP. And all of this is as while I'm looking at the patient and seeing what their airway is doing.
Yeah.
If their airway is like getting worse, I'm not kind of messing around with all these other things.
Yeah.
So let's get this airway secured because angioedema will go away in time. But the thing that is worrisome is that airway that's progressively narrowing.
Yeah,
So that's my disclaimer. We're not like trying to say, let's stop the airway by waiting for all these drugs. But yeah, TXA and then FFP. And then I've seen reports on people who give C1 esterase inhibitor for people who are non-familial, like type. And I actually know this because there was a patient who came in recently and I wanted to she is familial. And do you know the cost of one dose?
No.
It's like $17,000.
Oh, wow.
And the pharmacists were trying to convince me not to give it because they're like, this is an individual who comes in quite often and has been is unsure whether or not they respond to it. I was like, really? So we're gonna roll and there was no airway involvement, in fairness. But I was like, I want to give it. I was like, this is what this drug was designed for and tested for. We should give it. So just it is third on my list for patients with non-familial because it is so expensive and it's unclear whether or not it benefits those people.
I gotcha.
You know?
Okay.
All right. So we've given our medications or the person's airway is getting worse. We should pivot to that. What are we going to do?
So I think I'm going to shift the conversation to you, and that by the time I'm called, I'm an intensivist. I don't work in the ER. So by the time I'm called, all this work has already been done. So tell me, who do you NPL? How do you really think about it? There's a subset of patients that you just say, nope, I'm just going to take the airway. We're done with this. I can't. What's your thought process?
For most of the people who present with lip and tongue swelling, most of those people don't have any involvement in the posterior pharynx.
Mm-hmm.
I don't have the stats to tell you, but like I know from the literature, not everyone presents with posterior pharyngeal swelling. I feel comfortable NPLing folks because I think it is important that anyone that comes in with airway swelling, so that I have comfort when I leave that person's resuscitation room and I go back to see another patient, that their airway is open and clear. Not everyone has access to it. Not everyone knows how to do NPLs. So what I would say is if you have somebody who just has the lips and maybe the anterior portion of the tongue swelling, you could say with some certainty that the posterior pharynx is not involved and be okay with that person. Like I said, I do NPL folks, and I will NPL folks faster if I have somebody that is having trouble with secretions, trouble swallowing, with having difficulty with phonation, whether subjectively or objectively. Now, for me, the NPL scope, which is the nasopharyngeal laryngoscopy, just for you, it's the Fiberoptic scope. You could do it nasally, you could do it orally. I just want to make sure we cover that. And we'll go into some detail about how we do that practically later. But for me, there's really two branch points. Am I going to do the NPL with just to take a look at the posterior pharynx and get a sense of their airway? So I'm just taking a peek, knowing with some confidence that the airway is going to be okay, but I just want to check in on things? Or am I going to do the NPL where I'm going to take a look, and this might be the only look I take. So I'm going to preload an endotracheal tube on top of that fiber optic scope. I'm going to go ahead and start numbing that person up. I might even give that person some ketamine to dissociate them so I can tolerate the procedure. Because I know when I go take a look, if I see that their hypopharynx is crowded with edema, or I see their cords are swollen, I want to not pull out and get everything ready and go to intubate. I actually just want to go ahead and pass the tube over that NPL and get them intubated that way. So it's a one look type thing for me. If I know that person's airway is going to be threatened.
I see.
You know what I mean?
I see.
So
I'm thinking of like three variety of patients. There's the one that your pre-test likelihood of their airway being fine is high.
Yeah.
That's just a look-see.
Or that their airway
is fine.
Is fine. Yeah.
Correct. And that's mostly because then when I come storming down at 3 a.m. I'm going to say, what's the NPL show? You can be like, it's good. Don't worry.
Right.
But you get an idea for it.
And it's also to triage them to say that maybe they can go home. We'll talk about the progression of things.
But if they get clinically worse, you take a second look.
Exactly.
And you're like, okay, this progression
is
a lot
different.
faster than I thought.
Exactly.
And then there's a second group of patients, which are, I'm worried about that airway. And I really think if I find what I think I'm going to find, then I'm going to have to intubate. And that's the one you preload. And then there's a third group, which I'm sure we'll talk about, which is they need an airway now, maybe not a surgical airway. Maybe we can get this done safely. And that's the ones where you're doing NPL with the intent of intubation.
Yeah, I'll just the middle one. I think you said preload, and that's a
Oh,
plus
I'm
minus.
sorry.
That's okay. I don't. If they're, I'm worried. Listen, if I'm worried about somebody, it's getting preloaded, and I think it's a good exercise for everyone in the room, for the trainees, the nurses, to always get in the mindset of like, let's act like this is going to be an intubation. So we'll get the medications drawn up. We'll open up the airway box. We get everything ready, even when I know that we're not going to intubate the person.
Yeah.
I just want everyone to go through the simulation of what we're going to do. So that's always helpful. But yeah, if I'm working alone and the person's phonating well, I'm just not sure about the base of their tongue if it's swollen. I might take a look, knowing full well I can come out another 5 minutes, get ready to go back in and intubate if I do see something that I wasn't expecting. So that's my approach. Yeah, I like how you divide it up. I never thought of it like that. It's just really 3 boxes. The airway that I'm just really going to watch. I'm confident they may even go home that day. The airway, I'm somewhat concerned we should take a peek. And they were like, I'm really concerned. Everyone stop what you're doing. 5 alarm fire. We need to be in this room right now because this person is the only person in our department right now. Yeah. Good point.
And I wish there was a concrete way of really to say this person definitely belongs in each of these boxes.
Yeah.
But I think it's probably just experience in clinical gestalt and just.
It's the number of beads of sweat on my forehead
right.
is really how I determine it. It's 0 beads of sweat versus I need to change my scrubs. That's usually that's my meter for how bad it is. So then, like you said, you're getting these patients who have already been evaluated, right? And so you're going to utilize like ENT services if they're not intubated, right? And they're up on the unit and watching, right? You're going to call them in to scope them for you. Or would you do a fiber optic scope up there?
That's a great question. I don't know the answer. I feel comfortable. I'm pulmonary trained. I feel comfortable with bronchoscopy.
Right.
I definitely feel comfortable navigating and finding the vocal cords from the nose. I definitely do awake intubations.
Yeah.
Generally do not take a small scope just to look. If I really think there's upper airway pathology and they don't need an airway, I call ENT.
Yeah.
If I think there's upper airway pathology and they do need an airway,
right.
I have an approach to that.
And I think that's also a good point too. I don't want people to be like, I know how to do NPL, so I'm going to start doing these. If your comfort level is very good with NPL, as mine is, then do that. Have the comfort in doing that. If there's any doubt in your skill set right now, and while you're getting better, definitely get ENT, because not only can they help you with the evaluation, but also securing the tube, right? And also anesthesia as well. This is a very high risk patient, and I don't want anyone to try and be crazy out there. Just say like, oh, this is something I should be able. This is a very serious airway emergency, and if you have not done a fiber optic intubation before, or you've not dealt with an airway that is potentially this devastating, this is not one that you want to do on your own. In fact, would you say right before we started, like you call your friends up?
Call all my friends. I'll be like, I like to have in the simplest airway that I think is like slam dunk, whatever, seizures, SATs 100% on room air, no obstruct. I think it's going to be an easy airway. I like to have 2 competent people in the room always. And in scenarios where my fellows are off to conference or not there, I call another attending. And I don't, unless I have to, I do not walk into that room by myself and do it alone. And it's the same thing. If I have an upper airway pathology, I'm calling, in this case, it's usually trauma surgery, but it's surgery, whether ENT or trauma surgery. And I call anesthesia. And I say, hey, I'm worried about this. And I just want to make sure everyone's available.
Agreed. And it's the same thing I do as well. Just to have another hand, some in the room, even if it's another fellow intensivist with me or emergency medicine physician, if I'm in the department, I just need another set of hands. And I think the older I get and the more experience I get, the more at liberty I am to do those calls. I don't feel bad about it. I say, listen, I just want you to come be in the room. Like you could bring some stuff if you want to. I'm not asking you to do this airway. I just want you to be there just in case. And maybe 1 time out of 10, like that person would need to step in and actually do something because I'm not able to achieve what I wanted to do.
The other point to make is, let's say you don't call them and then you need them. That's who's going to call, what's the number? It's always a cluster.
Where are they? Are they in another emergent case? Are they just simply at lunch, and they have to rush from the opposite side of the hospital to get to you?
Yep.
So just having that person nearby, and most times they don't do anything. They're just like, hey, thanks for calling. We're good. And we're good. Thumbs
Yep.
up. You did the procedure on your own. Great. So where else are we going to go after that? Do you want to talk about the preparation for the awake fiber optic?
Yes, I think we should talk about the preparation. And
while you do that, I'm going to check the comments.
cool. So I think I'm just trying to think of, and what I always think it's nice to break them into different groups of patients. So I think let's just say the Airway. So they come in, they're hypoxic, they have stridor, the tongue is huge, it's crowded the mouth, you're really worried, you don't really want to take time to do NPL so I think that's a certain approach versus how you're going to do an awake intubation. Those are probably two separate patients. Once again, if I have to crack someone, then that's what happens. Generally, it's a call to a surgeon. And I think my preference in terms of meds and how I do that would be prep the neck, dissociative ketamine, some benzos, some opioids, PRN as I need it, and then proceed with kind of semi-awake cric.
Yep.
And that's probably the way to do it in the patient that's like an extremis and trying to die. And definitely not RSI, definitely not just, let's just give them the Etomidate and see if they need rock. We'll put in, that's probably not the way to go.
Agreed. And there's a couple things I want to build off that. This person, you do not want to paralyze them. You do not want to take away their work of breathing. In fact, the fact that they are actively inspiring opens up that airway as they're taking a breath. You take that away, you might lose that little tiny pinhole, which I've been there. Sometimes it's just a pinhole is all, and you're just going for it and pushing through. You don't want to lose that. So keep them awake, spontaneously breathing. These fiber optic intubations, they also take, and I should say, like we're talking fiber optic, doing a direct or video laryngoscopy is also okay too, as long as they're awake. But these ones take time. This is not one where you're just going to go in, slam the tube in. So keeping that person awake and breathing is going to allow them to continue to oxygenate and ventilate, which is what you want for this person. And when you're doing this approach, you can quickly anesthetize them. Sometimes you can take your time and get good anesthesia of the upper airway. I agree with the ketamine. I like to use some opioids as well, multimodal therapy, so that they're relaxed and they're tolerating it. Yeah. And then as you're going through and as you're getting to the point where you can get through the cords, if you have someone that's choking or gagging and you can see something, you can consider giving paralytic only when you're seeing that cord.
Yep.
And you're just using 100%. It to style it through. So you're pushing that fiber optics go through the cords. In fact, let me get this. Pushing the fiber optic scope through and dilating that tissue. The other point to mention is that this is why it's good to have backup, is that every manipulation, every touch point of you on that mucosa makes things worse. This mucosa is extremely edematous, extremely friable, can bleed on you. And if you're not careful and you just screw around in there too much, for lack of a better word, you can make the airway much worse.
Yeah,
than you wanted
to. Actually, I'm gonna build on that. It's a little bit of an aside, but I think it's maybe a good teaching point.
Yeah,
is that know the mechanism and how long it takes of each of your drugs. And anyone who's intubated with me, they'll see me. I'll be in the room and we'll push Etomidate, and I'll say Etomidate in at 20 or rock in at 45. And the point is that I'm gonna wait the full for rock. I'm gonna wait the full minute to a minute and a half before taking a look. Because similarly, if you choose to do RSI, I feel like the worst thing to do is to then not allow the paralytics to take full effect. Go in there, try to jam your tube, you cause bleeding, you cause swelling, and all of a sudden now they're paralyzed and you've messed up the airway. So you have the luxury to push meds, know how long they take, and let them work. So many airways, push, and then 10 seconds later, they're like taking a look.
Yeah.
Give it time to work. Good ambu bag mask valve, and just wait until you're ready to go.
For any airway too.
For all airways.
All way too. And I tell the trainees, fellows, or residents that someone's gotta keep time. Like you'll always see me, either it'll be me holding up a clock to the room, like I'll hold my iPhone the Superior phone, by the way. You can sponsor me. I'll hold it up in the air just so that you can see the timer. And I was like, we are not laying the head of the bed flat until we get to 45 seconds, right? You're not opening the mouth until we get to a minute, right? But there's this temptation. It's like when it's go time, it's go time. And the worst thing you can do is have a person who you lay flat who's not really paralyzed. You start to de-recruit, you lose that FRC, and then you're trying to open their mouth. I guess they're not ready yet. And then you put the bag on, then you start bagging them while they're still awake. You just get caught up in, I got to do something. Stand there, don't just do something, I think is the best line that I've ever heard. So
we had a patient. I had a patient. It's an upper airway pathology, so I think it works.
Yeah.
And she, I don't know, she was in her 30s, no history of smoking, but has been coming recurrently in to different hospitals for asthma. And I felt like asthma at 30, this is strange, but possible.
Yeah.
Sure. And we had her. She was in rough shape in the ER. We got her up to the ICU because I was a little worried. She comes up. She's Strider. I'm thinking back.
Yeah.
She's Strider, in and out, tripoding. And my fellow says RSI. And I said, why don't we just give etomidate and see what we got?
Okay.
And we can have a whole conversation about rapid sequence versus delayed sequence versus paralytics on everyone and paralytics on no one. I think that's a worthwhile conversation. But we chose not to. And when we took a look, she had a big mass sitting right at her vocal cords.
Ah, interesting.
And it was the same thing. And it was a thought process. Do we try to jam a tube in?
Right.
Or do we just do ambu mask and just sit there and bag her until our friends come? We ended up getting it and went fine.
Interesting.
Yeah.
I thought you were going to go with a case of vocal cord paralysis or paradoxical vocal cord movement and other things that present late in life.
Yeah.
Right?
That's cool.
As an interesting case. Oh, interesting. Yeah. So I think not having one method of approaching airways, not having RSI for everybody is really important. And for anyone out there who doesn't know how to do awake intubations, it's a skill set worth learning and practicing with someone at your hospital who's facile with it, because there's so many situations where it's important not to take someone's respiratory driveway and do it. Yep. Cool. 100%. How about Craig? Is this someone that you're going to call general surgery? Yeah, surgery for. Yeah.
This is someone you have to, but this is someone I'm going to let surgery do for sure.
Yeah. And for me, I've done Craig's before. I feel very comfortable doing them. I would say a person who's in that third box, we're loading up the tube, we're getting everything ready.
Yep.
This is someone that I actually would start even prepping the neck. I might let the patient know and their family know in the room, although I don't want to put too much stress on that patient. They're already working to breathe. But I want to know where their landmarks are. Anytime I intubate somebody, I actually just go and palpate their larynx. I try to find the cricothyroid membrane. But if you have somebody who's, let's say, morbidly obese, right? And we won't get too far into the weeds here, but this is an opportunity to take ultrasound and actually mark with the ultrasound machine where your cricothyroid membrane is and actually make an X on it, just in case you need to go that route. Being prepared, knowing that you might have to do a cric for this person is absolutely essential. Cool. All right. So let's say we get the tube in, right? It was a little dicey. You were confident. You did it all right. You had all your friends in the room.
That's all the friends.
And what do you do in post-intubation in terms of analgesia, sedation, paralysis, vent mode? I want to know everything.
My dream would be to live in an ICU that doesn't use opioids and uses Precedex or dexmedetomidate, and really avoids that deep sedation in everyone.
Yeah.
These are the patients that I deeply sedate.
Oh, okay. Off the bat.
Yeah, they're already paralyzed.
Yeah.
Maybe they're paralyzed.
Okay.
But yes, I deeply sedate most of them. And because usually you're going to want to get a CAT scan, see what's going on in the neck, see what else is happening. And I usually deeply sedate them all.
So peri-intubation, you're deeply sedating them because they have to get adapted to the tube. You might have other things that you want to send them for. Hours later, they're just chilling. Are you keeping them deeply sedated also? Or are you starting to let them breathe spontaneously, do stuff on their own?
I think it just depends on the tempo.
Yeah.
And it depends on the etiology, right? So if it's upper airway from a mass, I'm probably going to keep them deeply sedated.
Okay.
Because they're going to need some sort of surgical excision or trach or whatever. That's not going to get better.
Sure.
Now, if it's something like angioedema, honestly, usually you get a sense because the tongue goes down.
Right.
You get a sense of the clinical course. And I'm more than happy to, and I do slowly wake them up and try to decrease. And it depends on the patient, right? If they're wild and they're
sure.
Tube,
Sure.
We're not sedating. Sure. I will shoot for awake and cooperative.
Yeah, I think I agree with you. Like initially, when things are cooling down, the last thing you want, especially for that pinhole airway, is that person yanking out the tube on you because they coming out of their haze,
Yeah.
they just feel something in their throat. They just want to yank it. But as you get down the road with experienced nurses who are going to be at the bedside, yeah, I think it's totally fine to give them some analgesia in the background and to start to wean things off and let's see how they do because I want them to spontaneously breathe if possible. I think if they can tolerate, put them on pressure support, let them determine their own minute
Yeah, I
ventilation,
would
their own
agree with
tidal
that.
volume. And then hopefully in the next 24 hours, again, get that tube out. So I don't
Yep.
have to worry about weaning sedation. It's probably too quick for delirium to happen, but still, keep them as light as possible. But you're right. There are some people who come with other stuff and other, let's just say, afflictions, and they can be
Right.
pretty wild. This is not somebody. If there's any chance of that, I do not want that person. I
Yeah.
agree with you. The last thing you want is a bloody edematous airway from not only their initial airway, but them pulling the tube out.
And
That's
coughing
and
and like,
cough. Yeah, it's a
And
mess.
this is actually good. You're talking about like vent settings too. This is someone who, if you're going to put them on full support, it's like shoot for physiological vent settings.
Yeah.
So listen, I love ARDS. I love proning.
I heard that
that's
you
my
like
thing.
proning.
And, but this is someone who doesn't get 6 cc's per kg.
Yeah.
I'm breathing 700, 800. I'm taking deep breaths right now and I'm okay. And so I think that this is someone who you can put on 500 or 600
Yeah.
and probably be safe as long as the airway pressures are okay.
Sure.
And let them breathe at a rate of 10 or 12.
Right.
You don't have to do strict because that's just going to make them more uncomfortable and
Yeah.
desynchronous. Then you're going to need more sedation and you're just going to spiral down.
Yeah, that's a great point. And that's why I favor pressure support whenever possible because they'll figure it out. And I know sometimes the trainees, they come down, I thought you said 8 cc's per kg. It's like, that's a protective lung strategy. Here we're doing the protective airway strategy, which is just that tube is only there to protect that airway from closing in. Everything else about that person's physiology is absolutely normal like it was yesterday. And then they're like, oh, okay, I get it. Hopefully that makes sense to everyone out there. And please drop your questions in the comments. We're going to be addressing them in just a little bit. How about getting the tube out? Because
Right.
I find that's a place where once you have the tube in, that's great. But when do you pull the trigger to extubate those people?
So I use cuff leak and essentially decreasing the cuff. And if you hear,
I was going to say auditory, or you look at the vent for.
so let's talk about that. So when you look at the vent, the way to really look at the vent is they need to be deeply sedated,
Right.
fully synchronous, and have 10 cc's per kg, enough of a tidal volume that you're going to appreciate a difference, right? So if you have them on 300 cc tidal volume and decrease it, it can be hard to see. So I tend to just listen and I don't worry because we usually do the cuff leak after they pass the pressure support and are awake and we're thinking about it.
Right.
We don't do it at the beginning when they're
Right.
sedated and on a continuous mode, right? And so that's usually what I do and I wait for a cuff leak in these scenarios. That's different than the patient who's got a prolonged intubation who doesn't have a cuff leak. Those patients, if they don't have a fixed mass, I give them steroids. I don't check it again, and I get them extubated in 24 to 40 hours. Does that make sense? The difference between the two?
Totally. And the thing that I'll say is cuff leak is probably more important in this patient that we're talking about today because likely whoever put that tube in is putting in a smaller tube. The airway was threatened. It was a really tight airway. They're probably going for a smaller tube anyway. So if you're putting in a smaller tube for that person that they would normally have and you don't hear a cuff leak, that means that there's probably some significant swelling.
Yeah.
If versus the person who it's the 5'5" female, they put the 8.0 tube in because they got the 8.0 tube in. It's I don't hear a cuff leak. It's like, yeah, because that's probably just fitting snug.
You don't need a cuff.
Yeah, you probably don't need a cuff. That's good. So that's my thought on that.
I agree.
Do you call ENT also? Because I sometimes I when I first started record, I used to call them like, "What do you want to say? We can't see anything. We'll do it, but can't tell anything."
I was waiting for you to ask me about do you put a scope in and pull the tube and look with the scope?
Yeah.
The answer is no, I don't do that.
Yeah.
It's the same thing like an exchange of a line over a wire. I don't believe you can't do it sterilely.
Yeah.
I don't think you can. I just have never seen a way that
stay safely. Yeah.
Like,
how about the
you're ready to pull it, you pull it out.
The Cook catheter where patients like,
Yeah,
they're like, oh, we just gotta give a little more time and relax, sir, relax. It's okay though.
Yeah, they're gonna put a tube exchange in. I'm gonna put a bougie in. I'm gonna take the tube out. I'm gonna see how they breathe.
It's gonna sit at your carina. You'll be fine.
They have something through their vocal cords. They're not gonna breathe. I hope this makes sense to everyone. We're not just talking jargon. But yeah, I don't do that.
No, agreed.
If it's ready, they're ready.
If it's ready.
Sometimes you're wrong, and then you got to figure it out again.
Yeah, what's the stat? I hear different stats about the reintubation rates. I always hear between 25 and 33% are the rates of reintubation in an ICU, like acceptable reintubation rates.
Oh, that's a good. I don't know. It's your preference, right?
Yeah, I know. I guess that's true because there are some
10
people.
to 20 is what I hear.
Yeah, 10, 20. Okay. Yeah, I always hear the quarter, and that's what I usually tell patients' families too. We're doing all these tests, but there's a 1 in 4 chance that we're going to have to put the tube back in, but we're going to try not to if we can avoid it. Yeah. Okay.
Right.
What else do we need to talk about?
This is one that I'm shooting for a 0.
Oh,
this is the one that I'm not saying, no, if I have to reintubate, I have to reintubate.
This is the one you drag your heels on because there's again, the reason why you put that tube in is because there's significant narrowing. Yeah. You wait.
Yeah.
Now, there have been situations that I've come across where you're waiting a long time. You're like at 4 or 5 days, and now you're like, are we going to have to trach this person? And I think there's a little bit of wiggle room. There are some things that you have to figure out there. We probably should talk too much about that because that's clinical judgment and whatnot when you pull a tube after 5 days. But for most people with bradykinin-induced angioedema, 24 to 48 hours should be, once you remove the offending agent, 24 to 48 hours should be the physiology should be resolved at that point.
Yep.
So, yeah. Well, that's really interesting. Anything else that we had on our list of things we want to talk about?
No, so I think we did little pathophys.
Yep.
We did some presentation of the 2 different types.
Yep.
We talked about treatment for both. We talked about intubation approach, triage, vent management, sedation, extubation. We did a lot.
Yeah, for sure. I don't know if the mic's going to extend, but let's see. Let's get some questions here.
While you're prepping, I will say one thing you mentioned trach, and I think it's important to note that I don't consider almost ever tracheostomy as a failure. There's this kind of feeling that we should never do trachs because it means that we failed to get them extubated. And I think sometimes it's just the best pathway to getting better. I don't know if you agree with that. So if you have an upper airway pathology, you really don't think it's safe. And I don't think doing a tracheostomy is necessarily a wrong thing to do with patients.
Here's a good question here from Robert Bowman. Good to see you, Robert. Always participates in the lounge and some of my live streams. When discussing need to secure the airway, how does the need to transfer a patient come into the decision? Does this lower your threshold to secure an airway or not affect your decision? What do you think?
So I'm always on the receiving end of these patients, right? And a little pet peeve of mine is when people not standing next to the patient gives clinical advice. I hate it when the fellow tells the ER things before they go and see the patient. And similarly, I think it's just a clinical decision. I think if you're worried, it's much better. It's better to take the airway and send them safely than to send them on high flow and hoping they make it there.
Yeah. Again, I'm with you. I've always been on the receiving end of getting patients, and sometimes I'm talking to the person on the other end. What do you think? Should I take the airway? And my response is usually, that's your decision. You're staying with the patient. But the fact that you have doubt means you probably should take the airway.
I would agree with
and if you have the ability to call in, if you don't feel comfortable, you get anesthesia or someone to come, that's great. The tricky part comes is when you have these hospitals that are set up. The name just escaped me. What's wrong with my brain? These critical access hospitals, they don't have access to airway experts. Mm-hmm. What do you do with that? And that can be tricky. I would probably request a flight crew that is experienced in airway, or even some that can do cricothyroidotomy in the air. But yeah, those are the dicey ones. But again, you're putting someone on an aircraft, and we're talking about a disease in angioedema that can rapidly progress. So even by the time you hang up that phone, things can significantly change. So I always recommend taking the airway if you have any doubt at all.
I agree.